Alright folks, we're going to do some hormone studies today, along with some other electrolytes that we're going to find that can be regulated by some hormones. So here we go. We're going to start this presentation by taking a look at some of the electrolytes, specifically magnesium, phosphorus, and calcium. Okay, so let's start with magnesium. After potassium, this is going to be the most common electrolyte found in the intracellular fluid. Okay, now inside the body, most of this is going to be found in bone, and the rest will be found inside the cell. Only about 2% of this, though, is found in the extracellular space. All right, and most of magnesium is bound to albumin. Now, it stays in the bone for a long time, and it takes a significant amount of depletion before it's going to start to be ripped out of bones. So if you're noticing that a mag level is low, you're going to need to replace this, because if you're going to wait for it to be ripped out of bone so that the body naturally replaces it on its own, this will take a great deal of time. So when you're noticing that the patient has low mag, you'll need to replace that. So why do we need magnesium? Why is this important to us? Almost all enzyme reactions that use phosphorus need magnesium for activation. So some specific examples that I gave you here: ATP, right? Adenosine triphosphate. You've all heard of this before. This is really important for us in order for us to have chemical reactions, and it's basically our cellular energy is ATP. So magnesium is going to be really important in the synthesis of ATP. It's also very important in the synthesis of DNA and stabilization of RNA molecules. Magnesium is also used to help with energy storage and metabolisms of fats, carbohydrates, and proteins. It helps with the action potential of both skeletal and cardiac muscles. All right, now I highlighted a point down for you here. Magnesium helps to make the production of parathyroid hormone possible. This is going to be real important later on in the presentation, and you're going to see suddenly how magnesium, calcium, phosphorus, parathyroid hormone, vitamin D, and basically most of the things we're going to talk about in this presentation here today, how they're all interconnected and how they sort of rely on each other in order to function properly. All right. In addition, magnesium is also helpful in helping sodium and potassium cross the cellular membrane as well. We typically get our magnesium from the nutrition that we eat, and it's going to be primarily absorbed through the gut. Now, the absorption is really just based on the intake, but there's a lot of other variables that kind of assist in this process. Natural foods, foods that we kind of cook and eat at home, they tend to be a better source of magnesium versus processed foods that tend to lose magnesium through the actual process of processing it. All right. Now, high amounts of calcium in the gut, you're going to find that there's an inverse relationship with regards to absorption of magnesium and calcium. So when there's high amounts of calcium in the gut, then there's going to be a decreased amount of magnesium absorbed, and vice versa. When there's low amounts of magnesium in the gut, we will also increase the amount of calcium that we kind of bring on board or absorb. In addition, parathyroid hormone, when that's kind of out and about, that will also increase our gut absorption of magnesium. So there you can see they're already starting to show how these things are interconnected with each other. Now, the kidney also plays a role in our levels of magnesium. Typically, this is going to be magnesium, extra magnesium, will be filtered at the level of the glomerulus in the kidney, but a bunch of it is reabsorbed through the tubules. Now, if you have renal function issues, like in acute renal failure, then you're not going to be able to filter out magnesium, which will cause you to have higher levels of it in your blood, and this can lead to hypermagnesemia. So if you have a patient who's in renal failure and you notice that their mag is elevated, it's probably because it's not being filtered out due to the renal failure. It's reabsorbed in the tubules, all right, as I stated there in the second point. You can see at the bottom here, though, that it's not reabsorbed in the proximal tubule like most other electrolytes. Rather, this one is going to be reabsorbed in the loop of Henle and the distal tubule. So this is a little bit different. In addition to being different than other electrolytes, this is not regulated by hormones. Okay, there's absolutely no hormonal control over the excretion or reabsorption of magnesium. This is different than some of the other things that you've learned about with regards to potassium, sodium, and we'll talk a little bit further about phosphorus and calcium. I mentioned already that there is a relationship with magnesium and calcium. Now, on the previous slide, I talked about how magnesium is needed in the synthesis of parathyroid hormone. Well, why is this important? We're going to get into it a little bit later, but just to kind of start that conversation, parathyroid hormone is responsible for maintaining a constant calcium level in the extracellular fluid. Therefore, if you don't have enough magnesium, you can't make parathyroid hormone. And if you don't have parathyroid hormone, you're not going to absorb calcium, and so it's going to result in hypocalcemia. So that's going to be real important later on when we talk about parathyroid disorders. Magnesium also plays a role in the absorption of calcium, like I mentioned earlier. So when there's low magnesium, then you're going to have increased calcium absorption in the gut. And when there's high magnesium, you're going to have decreased calcium absorption in the gut. One more point to make here. You'll notice I gave you some normal ranges up here at the top. You can see that mag levels are typically 1.4 to 2.2. Now you know there's going to be a little bit of variation depending on your lab, but for the purposes of what we're doing here, those are going to be the levels that will demonstrate the normal range, 1.4 to 2.2. Hypomagnesemia. All right, so it's going to be less than 1.4. This is simply diagnosed with a serum mag level. You just order mag, you'll be able to see it. 40 to 60% of these patients will also be hypokalemic as well. Why? Well, because typically the cause of the hypomag and the hypokalemia is typically the same thing. Like it's either a diuretic or diarrhea or some other cause. So typically if you see there's low mag, there's probably going to be low K as well. There are a variety of causes that result in low magnesium levels, and many of them can be typically determined by just taking a good history. So as we stated earlier, there's an inverse relationship between calcium and magnesium. So if there's elevated calcium, then we're going to probably have decreased absorption of magnesium in the gut. So and that can be for any reason that you'd have high calcium levels. In addition, for whatever reason, when there's also high levels of calcium, that tends to inhibit the reabsorption of magnesium from the kidneys, and this can lead to elevated levels of mag and calcium in the urine. Another cause would be poor dietary intake of magnesium, which is really difficult to do, but if you have someone who just has really poor nutritional habits, it is definitely possible. Poor absorption from the GI tract. If you had a condition like celiac disease, or you've had a bowel resection, and you're not able to absorb magnesium that way, that can lead to low mag levels. Folks who are chronic alcohol abusers, that can tend to lead to tubular damage, and so you have less resorption or reabsorption of mag in the kidneys. In addition, if they're a chronic alcohol abuser, that can also lead back to the poor dietary intake. For many of these folks here, if their primary source of nutrition is just alcohol and they're getting their carbs from the alcohol, then they could also have a lack in their mag absorption as a result of poor nutrition. Another cause here is excessive loss from the GI tract. This includes both upper and lower GI tract issues, but mag loss, believe it or not, tends to be more common with lower GI tract losses, such as diarrhea. So it's going to be more common with diarrhea than it will be with vomiting. And the reason for this is that apparently there are higher mag levels in the distal gut, so as opposed to the proximal portion of the alimentary canal. So remember that you're going to see more mag loss with lower GI tract issues. In addition, patients who have like prolonged GI drainage from like an NG tube or excessive diarrhea or laxative abuse, you'll see low mag levels. I also just wrote in here, also seen with K. Remember, if there's low K, there's a lot of times low mag, low K. They kind of go together. And as you learned before, excessive GI loss can give you low potassium. So once again, you can see low potassium and low mag together. I gave you a little box down here just to kind of remember that there's no hormonal control over magnesium. So when you have low mag levels, your body is going to take where it needs it from, and the most abundant place is going to be in the extracellular fluid. So that's why there's a rapid depletion of mag when it's needed at the cellular level, because it's going to rip it out of the extracellular fluid. Remember, it takes weeks before it's going to start to be ripped out of bone. A few more causes here. Excessive loss from the kidneys, particularly if you're on an osmotic diuretic or loop diuretics. They can also get rid of the mag just like they do with potassium. Medications, and the most common offender for this one here is going to be proton pump inhibitors, especially omeprazole for whatever reason. If you've been on that chronically for a while, you should be checking mag levels on them. All right? And then I gave you that little box to remind you again that there's no hormonal control over the regulation of mag. All right, so if the cause of the low mag cannot be ascertained from taking a history, then we may have to do some testing. Now, you can do a couple different things. You can look for a fractional excretion of magnesium, an FE-mag, kind of like what we talked about earlier with fractional excretion of sodium, or you can do a random spot urine, or you can do a 24-hour urine collection to also see if it's being wasted from the kidneys. And this will help us decide whether it's from renal cause or a gastric cause. All right, so let's say you get a urine test. All right, if you're excreting more than 10 to 30 milligrams of magnesium in a 24-hour period, or if your fractional excretion of mag is greater than 2, then these both indicate that it's renal wasting of mag. If the urine study is normal, or if the fractional excretion of mag is less than 2, then this is going to be probably from GI loss, is going to be the cause of low mag. All right, moving on now to hyper mag levels. Okay, this is going to be greater than 2.5. Easily diagnosed. How do you do it? You just get a mag level and see that it's high. Most common cause, renal failure. As we mentioned to you before, this stuff is going to be reabsorbed in the kidneys, and it's also kind of excreted through there. So if the kidneys are not working appropriately, this can certainly lead to high levels of mag. And once again, not regulated by hormones, so if mag levels are high, there's nothing to stop or slow down reabsorption because there's no negative feedback loop here because it's not regulated by a hormone. Other causes, magnesium infusion. If you have a patient who's pregnant and they might be treated for preeclampsia with a magnesium drip, that certainly can elevate their mag levels. Through oral ingestion or things like enemas, particularly things like over-the-counter antacids like milk of magnesia, all right? This is also problematic in people with renal failure. So they already have the renal failure, which can cause high mag levels, and then if they're ingesting extra magnesia on top of that, because there's no hormone regulation, this can certainly lead to high mag levels. So in your patients with chronic kidney disease, you have to be careful about them using some of these over-the-counter supplements that are useful in with their GERD symptoms and reflux to help with their dyspepsia. So just provide some good education to your patients about that and maybe follow their mag levels. Other things like hypercatabolic states like tumor lysis syndrome in some cancer patients and things like DKA, those can also raise your mag levels. Moving on to phosphorus. Normal phosphorus level is going to be 2.5 to 4.5. 85% of phosphorus is found in the bone with calcium, and the remaining 15% will be found in the intracellular fluid. Now, just like with magnesium, there is an inverse relationship between calcium and phosphorus. Increased calcium results in decreased phosphorus, and vice versa. So when there's high phosphorus, then we have low calcium. This is because serum levels of either calcium or phosphorus will cause the kidney to excrete the other. All right? So I'll say that again. When there's excess serum levels of either calcium or phosphorus, the kidney will excrete the other one. All right? Now, these is going to be controlled by hormones. The main one here is going to be parathyroid hormone. This is going to play a huge role in calcium regulation in your body, and we're going to get into that in a little bit. Why is phosphorus important? Well, we need it to help us with generation of bone, metabolism of glucose and lipids. It does help with the acid-base balance, and it's important for storage and transfer of energy. Remember, we were just talking about ATP, so it's a very important electrolyte to have in our body. Hypophosphatemia. It's going to be phosphorus less than 2.5. This is typically easy diagnosed by a simple serum phosphorus test. The cause is typically determined on the history, very similar to magnesium. The normal response for the body to take when we have low levels of serum phosphorus is to simply reabsorb it in the kidneys. Some of the reasons that you could have low phosphate have to do with glucose entering the cells. As glucose is allowed to get into the cell, a lot of times phosphate or phosphorus will go with it, and so you can get a temporary drop in your phosphate levels following absorption of glucose. So this could be after you eat. You might notice a drop in your phosphate levels. It could also be from inadequate intake. However, this is rare because this electrolyte is so readily available in the foods that we eat, and your kidney is so good at reabsorbing this as it goes through the renal system that it's not as likely. You can also see it with antacids containing aluminum or magnesium. However, now that people are using more and more H2 blockers and PPIs, it's not real common as a cause for hypophos levels. Chronic diarrhea, you can certainly get rid of phosphorus that way. So that would be just another cause. Two key players here in the role of low phosphate is hyperparathyroidism and vitamin D deficiency. Parathyroid hormone actually increases phosphate excretion. And as you remember from before, parathyroid hormone regulates our calcium levels. So when you have hyperparathyroidism, that can cause an increase in calcium, which we know will cause increased wasting of phosphorus. Remember, there's that inverse relationship between the two. So PTH actually increases phosphate excretion, and also with hyperparathyroidism, it causes calcium to get levels high, and we know when calcium levels are high, phosphorus gets excreted. Coming down here to vitamin D deficiency, vitamin D is actually needed in order for you to absorb phosphorus from the gut. So if you don't have vitamin D, you're not going to pick up phosphorus out of the gut. In addition, vitamin D can actually cause a secondary hyperparathyroidism, which we'll talk about a little bit later. But as we just mentioned up here, hyperparathyroidism results in increased phosphorus excretion. So these can be two pretty significant causes of hypophos. All right, let's go to the other extreme now. This is hyperphos, and this is going to be a phosphorus or phosphate level greater than 4.5. This is typically just diagnosed on a serum laboratory test. There's no fancy test for it, and the cause is usually determined by taking a good history. All right, let's look at some of the causes here of hyperphos. One of them being kidney failure. Just like with magnesium, like we talked about earlier, if the kidney is not functioning well, it can't filter out extra magnesium, and same case here, it won't filter out extra phosphorus. So it accumulates in the blood because it's no longer being filtered out by the kidney. The second one here is low PTH, or parathyroid hormone. We stated in the previous slide that if parathyroid hormone is increased, that's going to cause more calcium to be ripped out of bone, and so calcium levels are high, and we know when calcium levels are high, phosphorus is excreted out of the kidney. In this situation here, if you have hypoparathyroidism, then that means there's less PTH circulating around, so calcium levels will tend to be low, and phosphorus remains in the body because it is not excreted as well from the kidney, because PTH in many ways tells the kidney to get rid of more phosphorus. Just like we mentioned here, hypocalcemia. When calcium levels are low, phosphorus levels are generally up. Cellular destruction, we can see this here as well in conditions like rhabdo or tumor lysis syndrome. And then, of course, excessive use of laxatives or enemas that contain phosphorus, that can certainly raise your phosphorus levels. All right, we're moving on now to calcium. 98% of this is stored in the skeleton, and the remaining 2% is kind of split up. Some of it's bound to a protein, and the other is ionized. Ionized calcium is what is the usable calcium to our body. The other part of it being stored. So stored calcium is basically a reservoir. It's a bank, if you will, of calcium. When our body needs more of it, we pull it out of storage. It's got to get made into ionized calcium because ionized calcium is the calcium that our body is able to use. When you're ordering a test, all you're going to get is a general calcium. If you need to know what calcium is ionized, you specifically need to order an ionized calcium level. All right? If you just want a calcium level, not specifically ionized, then you would get what's called a total calcium level, which is when you're getting a calcium, that's pretty much what you're getting. If you're getting like a complete metabolic profile or something like that, you can get a calcium in that, and it's going to give you this total. Otherwise, you have to order an ionized calcium, or what a lot of people will call an iCal. Because calcium is bound to protein, a decrease in albumin will result in a profound decrease in serum calcium. If this is the case, then you have, in order to get an accurate calcium level, you have to adjust it for the low albumin. So there's a little equation here, which is simply the serum calcium, all right, and then you're going to add that to the normal albumin minus the serum albumin. In other words, the normal range minus what you're actually getting on your test. That gets times 0.08, and that'll give you a corrected total calcium. So the example down here was a serum calcium of 7.8. The normal albumin should be around 4 minus the serum albumin of 2.8. So if you plug those numbers in down here, this actually gives you what appears to be a serum calcium of 7.8, but the corrected one is actually 8.76. All right? So once again, if you have low albumin, you have to correct for it to get a better picture of the actual calcium that's in the body. All right, let's look at some of the factors here that regulate calcium in your body. Two key players here is going to be parathyroid hormone, like we mentioned before, and calcitonin, which we'll get into in just a second. Low calcium levels in your body, or basically in your blood, stimulates parathyroid hormone to be released. The parathyroid hormone will actually pull calcium out of your bones in order to elevate and regulate the calcium levels in your body. Once those levels are elevated, it acts as a negative feedback loop to turn off parathyroid hormone. All right? Calcitonin is a hormone that's actually made by the thyroid gland, and it basically is a direct antagonist to parathyroid hormone. Now, this really has four functions to it, okay? It inhibits calcium absorption in the intestines. It inhibits osteoclastic activity in bones. It stimulates osteoblastic activity in bones, and it inhibits the renal tubular cell reabsorption of calcium, thus allowing calcium to be excreted in the urine. Now, there is one factor here that makes calcitonin similar to parathyroid hormone and not a direct antagonist, okay? If you remember, when parathyroid hormone levels are increased, calcium is reabsorbed by the kidney, but phosphorus is excreted out. Well, calcitonin is a little bit different in that when calcitonin levels are high, it promotes the excretion of phosphorus and calcium. So calcitonin levels will tell the kidney to get rid of phosphorus and calcium. So that's the only difference that's there. All right, vitamin D. All right, vitamin D, we know in order for us to pull calcium out of the intestines, we need vitamin D. So very important in the regulation of calcium. It promotes calcium release from bones, and it also promotes the kidneys to reabsorb calcium as well. So it's an important regulator with regards to serum calcium levels. As I mentioned earlier, phosphorus is very important with regards to regulation of calcium because there is an inverse relationship between the two. So when there's high calcium, there's low phosphorus. So remember, phosphorus inhibits calcium absorption in the intestines. And then when calcium is low, the kidneys will retain calcium and excrete phosphorus, like we've been mentioning already. Other things that affect calcium regulation that are not as potent, but they are there, are other hormones like androgens, like testosterone and estrogens, which is one of the reasons why postmenopausal women are certainly at increased risk for osteopenia and osteoporosis because they lack estrogen, which helps them to keep calcium where it needs to be in the bones. So this is why a lot of postmenopausal women need to be on calcium and vitamin D supplementation because they have lower estrogen levels in their body. Here are just the ranges for normal lab values for calcium. So total calcium is going to be anywhere from 8 to 10. We do have some panic values to worry about with regards to a total calcium. And that is a calcium less than 4.4. You can get sort of like a tetanus or tetany of the muscles, and it can also cause seizures. In addition, or in contrast to that, a calcium level greater than 13 can cause all kinds of electrical disturbances in the heart. It's considered to be also cardiotoxic and can lead to coma. An ionized calcium, if you're looking at that, the normal range for that is going to be 4 to 5.6. And once again, if it's dangerously low, can lead to tetany and convulsions, and if it's dangerously high, can lead to arrhythmias as well as coma. So I would definitely think you should be familiar with the panic values with regards to calcium because it will have dramatic effects on your patients and can be actually life-threatening. Another major cause of low calcium levels is going to be from renal loss. This can be typically due from medications like Lasix, a loop diuretic, which certainly increases the excretion of calcium. Also, renal failure, that results in the kidney not being able to reabsorb calcium. So those are two other important factors here that can certainly cause low calcium levels. In addition, if you have chronic kidney disease, that can impair the ability for vitamin D to be converted to its active form. And we'll talk a little bit more about that later, but if vitamin D is not active and working appropriately in your body, well, then we know that's an important regulator for calcium, and that can certainly lead to low calcium levels as well. Here's the workup for hypocalcemia. Step 1, make sure that the calcium level has been corrected for any low albumin using that calculation I showed you earlier in the presentation. Step 2, if the patient has any symptoms that are atypical, or if the total calcium is just a little low, then really you should check for an ionized calcium level, okay? But only do that if your lab is equipped to do so. All right, so once again, just to reiterate, step 1, make sure that the calcium is corrected for low albumin. Step 2, if the patient's symptoms are kind of atypical, or if the calcium level is just a little low, then you want to get the ionized calcium level, all right? Step 3, if a history is unrevealing, then you're going to want to get some labs, particularly a parathyroid hormone, a MAG, and a PHOS. Now with the parathyroid hormone, all right, remember that if hypocalcemia is taking place, that should be a good negative feedback loop to tell the parathyroid glands to start secreting parathyroid hormone. So if there's low or even a normal serum level of PTH in a patient who's got hypocalcemia, that's pretty strong evidence that a hypoparathyroidism is taking place because that low calcium should be telling the PTH to put out a lot of hormone. If you're not getting hormone from low calcium, then something's probably wrong with the parathyroid gland. Get a MAG level because we talked about how that has an inverse relationship with calcium and also as a stimulator or correction it's needed for the production of parathyroid hormone, and a PHOS. In the absence of kidney disease or in increased tissue breakdown like we talked about earlier, like tumor lysis syndrome or rhabdo, a low calcium with a high PHOS is basically diagnostic of hypoparathyroidism. All right, so that's important. So once again, if the history is unrevealing, you want to get a PTH, a MAG, and a PHOS. One more test you're going to want to obtain is a vitamin D level. Remember that a low vitamin D increases parathyroid hormone and causes hypocalcemia due to a reduction in the intestinal absorption of calcium. Remember, you need vitamin D to absorb calcium from the gut. In addition, vitamin D also decreases intestinal phosphate absorption. So knowing what this level here is going to be an important factor when trying to decide why there's low calcium levels in the blood. This little diagram I threw in here just to kind of help throw all the physiology together. All right, so let's take it step by step. Up here, we have low serum calcium. All right, low serum calcium here at number 1. And this stimulates the parathyroid glands to start putting out parathyroid hormone. Parathyroid hormone is released and it affects bone, and so we get absorption of calcium or out of the bones. And it also comes down to the kidney and tells the kidney to go ahead and reabsorb calcium. We'll also put out phosphate from the kidney as well. In addition, this is going to stimulate the kidney to convert vitamin D to its active form. So a couple things are going to happen here. Calcium is going to be ripped out of bone, and it will increase our serum calcium level. The kidneys will also reabsorb more calcium, and that too will also increase our serum calcium level. In addition, active vitamin D is formed, which affects absorption of calcium from the gut, leading to increased serum calcium levels. Once this level increases here, it sends a negative feedback loop up to the parathyroid glands and says, okay, you can shut off. So you can kind of get an idea now of how the whole system comes together. Let's talk now about hypercalcemia. All right? The most common causes of this are going to be either primary hyperparathyroidism or malignancy. The two of these together basically combines for about 90% of all cases of hypercalcemia. So basically, the diagnostic approach to this is to differentiate between the two, whether it be malignancy or primary hyperparathyroidism. One of the first things you're going to do is, first of all, is make sure is that any elevated calcium levels you find, you repeat the test to make sure that it's accurate and that what you're seeing is really what you're seeing. If you have old labs to compare this to, that's really helpful so that you can see if there's been a trend or not. Long-standing asymptomatic hypercalcemia is typically more suggestive of a primary hyperparathyroidism or another condition that's not real common called familial hypocalciuric hypercalcemia, meaning it's a family-based condition in which you have high levels of calcium in the blood and you're not excreting it out through the kidneys. So you have low calcium in the urine, high calcium in the blood. When you're looking at the levels of calcium, it's also important to look at the degree of elevation. Primary hyperparathyroidism rarely has a calcium greater than 13. Higher levels than 13 are usually more likely due to malignancy. And that 13 should be right around those panic levels where we start to worry. But if you're seeing a high calcium level that's usually 13 or greater, you have to be concerned about cancer. Now, when you're going to order your lab tests here, we're really trying to differentiate between parathyroid hormone mediated and non-parathyroid hormone mediated hypercalcemia. So PTH mediated is going to be obviously the primary hyperparathyroidism and familial type diseases, and the non-PTH are going to be other things like vitamin D toxicity, malignancy, any type of ectopic tissue. So that's where the badness starts to come into play. Here's some of the tests you're going to order. You're going to order an intact PTH. About 80 to 90% of people with primary hyperparathyroidism will have an elevated PTH. Some patients, though, can have a normal or the upper limit of normal of PTH when there's high levels of calcium. This still is considered to be abnormal because if you have a significantly high calcium level that's caused by primary hyperparathyroidism, then you should really have a much lower intact PTH level. So in other words, if I have a calcium of like 11 that's being caused by a primary hyperparathyroidism, my intact PTH level should be like low or non-existent. So if it's high normal or even just slightly elevated, that should tell you that this is still considered to be a primary hyperparathyroidism. Other tests you're going to want to get is a parathyroid hormone related protein. This is typically secreted by tumors and acts as like ectopic PTH on the bone and kidney. This is bad. This is typically seen when there's a malignant source that's causing hyperparathyroidism. You're going to look at the various vitamin Ds that are available. We've got the D25 and the 1,25 or 125. An elevated D25 suggests vitamin D intoxication. An elevated 125 suggests that this is either direct intake of calcitrol or an extrarenal production due to granulomatous disease or lymphoma or increased renal production that is induced by a primary hyperparathyroidism. So let's break this down for you in how the workup kind of comes into play. Step 1, check a repeat total serum calcium level. Make sure it's been corrected for the albumin. If something doesn't seem right, you could always get an iCal, but really, if the calcium's high, first step is to repeat it. Step 2, if the hypercalcemia is confirmed, then the next test you want is an intact PTH. Step 3, we're going to interpret this now. If the intact PTH is elevated or even just a little bit to high normal, then we have to consider some things here. It's likely that it's primary hyperparathyroidism, but we need to rule out familial hypocalciuric hypercalcemia. So what are we going to do? We're going to measure urine calcium excretion. If the urine calcium is low, then you have the diagnosis of familial hypocalciuric hypercalcemia. But if the urine calcium is normal, then you made your diagnosis of primary hyperparathyroidism. Okay, so let's go back. Step 1, repeat the test. Step 2, if it's elevated, get an intact PTH. If the intact PTH is elevated, you're going to get a urine calcium. Urine calcium's low, you've made the diagnosis of familial hypocalciuric hypercalcemia. If the urine is normal, you got primary hyperparathyroidism, and you're done. Now, if the PTH is low, then we're going to be looking at a non-PTH source for this hypercalcemia. So at this point, you're going to order a parathyroid hormone-related protein and the vitamin D tests. Okay? If the vitamin D tests and the PTH-RP are normal, then you have to consider other causes. But if the PTH-RP is elevated, then you better be scanning for malignancy in this patient. If it's not, then you look at your vitamin D levels here. If you got an elevated 125, then you should be getting a chest x-ray looking for lymphoma or something like sarcoidosis. If the D25 is elevated, well, then you got to go back to the meds, and that this person's probably taken way too many supplements or is on way too much vitamin D therapy. Here's just an algorithm that looks at the workup for hypercalcemia. All right, so let's go through this kind of step by step. Here, let me use my lightsaber. There we go. All right, so you diagnose an elevated calcium on a serum test here. So things that you want to do is certainly get a good history, look at any clinical features of hypercalcemia, think about the possible causes, and then from there you can see if it could be caused by any medications. But for the most part, if you can't identify a cause based on that, then you know you're going to go ahead and order an intact PTH level. So if it comes back as normal or even just elevated, the next step from there is to get a 24-hour urine for calcium to make sure that this isn't the familial disorder that we were talking about before. If it's low, then you know that you have the diagnosis of familial hypocalciuric hypercalcemia. If it's normal, if it's high, then you either have primary or tertiary hyperthyroidism. Now, if your intact PTH level is suppressed, then you have to consider this could be malignancy. So you want to order a PTH-RP. If that's elevated, then we consider this to be some type of cancer disorder from a solid tumor, or in conjunction with your ALK-Phos being elevated, you certainly could consider this being a bony tumor per se, or even other things like breast cancer. Also consider, like I mentioned before, with bone cancers like multiple myeloma as well. However, if you get a calcitrol level here and that's elevated, as we discussed earlier, that could be something like sarcoidosis or lymphoma, so you would need to look into those conditions as well. If it's negative completely, well, then we need to consider other alternatives or other endocrine disorders that would cause the PTH to be elevated. All right, so this just gives you kind of a little bit of an algorithm on how this gets broken down. Let's talk a little bit more about parathyroid hormone. When you order this, as I stated earlier, you're going to probably order this as an intact PTH. This is going to give you the PTH 1-84 and something called a large C-terminal PTH. But it doesn't give you the little small fragments of it. Now you can order something called a whole PTH, however, there's really not a whole lot of clinical benefit to getting those small fragments added onto that. So for the most part, the standard of care is to get that intact PTH. Also remember that PTH is needed to convert vitamin D to its active form. So consider that in the process, because you know that vitamin D plays a key role in everything here. So as I mentioned to you earlier, things like mag, phos, calcium, PTH, they're all sort of interconnected, and so it's really important that you have a grasp on each of these individual components when we're talking about the workup of calcium issues. Just a quick, easy review here of parathyroid disease. Primary hyperthyroidism, about 85% of that is caused by a parathyroid adenoma. All right? Secondary hyperparathyroidism is usually a physiologic response to low calcium. And this can be due to vitamin D deficiency, or it could be due to just poor calcium intake. However, it's most often caused by chronic renal failure, which results in our inability to convert vitamin D to its active form. If we don't have active vitamin D, then we can't help pull calcium into the gut. So that's important to understand that concept. So most often caused by chronic renal failure. Since we were talking about vitamin D, we'll give you a little bit more background information on this. There's two extrinsic forms of vitamin D. There's the vitamin D2 and there's D3. It's really difficult to maintain adequate vitamin D levels from diet alone, which is why we tend to get most of it from sunlight. However, you are finding more and more now that people are vitamin D deficient, and so it's something that we need to consider as a part of a differential diagnosis. This is just a review of how vitamin D sort of works in our body. So ideally, what we want to do is kind of get it down to this level right here. All right. So what we want is we want to get it in through our diet. Fish is a great source of vitamin D, or we're going to get it from sunlight. And this will translate into pre-vitamin D, in which the liver helps out by converting it to the D25. All right, that's kind of where we want it to start off with. Now, our body recognizes either low serum calcium or low serum phos. If we have low calcium, as we've stated numerous times already, this activates parathyroid hormone, which helps the kidneys to say, let's help convert more vitamin D to its active form. Same process here. If we have low phosphorus, that also helps stimulate the kidneys to produce vitamin D25 to 125, its activated form. From there, this promotes calcium absorption in the intestines and helps to increase our overall serum calcium levels. All right, so I hope that kind of helps tie it all together for you on how vitamin D works. Now, symptomatic or just overt vitamin D deficiency is kind of rare in developed countries because of the types of foods that are available in our diet. However, subacute vitamin D deficiency is actually very common. I actually had it a few years ago where I just had some kind of vague symptoms, but nothing truly specific. And we turned out that after some testing, found out I was pretty vitamin D deficient and required to be treated. If you suspect that your patient has a vitamin D deficiency, then you're going to want to measure a D25 level on them. Remember, this is the precursor to the 125, which is the active form of it. Don't order a 125 right away because this could be increased by secondary hyperparathyroidism, and so it's not going to be a very accurate test for you when you're trying to work up a patient with vitamin D issues. Now, what we're looking for here is a level less than 20. That's going to be most consistent with a vitamin D deficiency, as opposed to levels 20 to 30, which you'll find in a vitamin D insufficiency. Now, as the D25 levels fall, our ability to absorb calcium in the gut drops, and so our serum calcium levels will also fall. As a result, the PTH levels rise, which will help to stimulate the conversion of D25 to 125 so that we can do a better job of absorbing calcium. So basically what you're finding here is if you have vitamin D insufficiency, you may just need to put them on daily therapy of maybe 1,000 international units to help kind of boost their level up, as opposed to somebody who's got a true vitamin D deficiency, which they may require the actual bolus therapy of 50,000 units once weekly for 8 weeks, and then you reassess them at that point. Cortisol studies. This is our last topic for this presentation, so let's get started. This slide represents the normal physiology or the HPA axis. Basically, it looks at the negative feedback loop with regards to how we respond to cortisol levels in our body. So when we have a drop in cortisol levels here in the body, it's picked up by the hypothalamus, which releases the corticotropin-releasing hormone, otherwise known as CRH. That message is received by the anterior pituitary, and then they secrete out something called adrenocorticotropic hormone, otherwise known as ACTH. This message then is received by the adrenal cortex, and cortisol is excreted. And you can see as it feeds back in the system. This also depicts another scenario here. As our body's under stress, we need more cortisol, and so that sends messages here. The stress would also be we're using cortisol, so our cortisol levels will drop. So that feeds the same way, just like to the hypothalamus from here, down to the pituitary gland, and from the pituitary to the adrenal glands. So let's talk about the workup of someone suspected of having hypercortisolism, or what's known as Cushing's syndrome. The workup is typically initiated because you have a clinical history that is suspicious for a Cushing syndrome. Now, the symptoms with this are really nonspecific. They're obesity, hypertension, high blood sugar, irregularities in the menstrual cycle. So really the diagnosis here is going to need to be based on diagnostic testing because there's really no clear-cut symptomology here that says, yes, this is the disease and we've made the diagnosis. Now, something really important here for you to understand. There is a difference between Cushing's syndrome and Cushing's disease. Cushing's syndrome encompasses all causes of glucocorticoid excess versus Cushing's disease, which is hypercortisolism from over-secretion of ACTH by the pituitary gland. So Cushing's disease has to do with something affecting the pituitary gland's release of ACTH versus Cushing's syndrome, which basically encompasses all causes of glucocorticoid excess. So it's important that you're able to differentiate between those two, and I'm going to teach you about some tests that will help you decide between those two diseases. Our bodies need cortisol to help deal with stress. So there can be times where you're going to have elevated cortisol levels, which is simply just physiologic, not necessarily pathologic. So in cases of physiologic stress, such as sepsis or an acute illness, you're going to have higher levels of cortisol flowing through your body. Other conditions such as severe obesity, particularly in people who have more visceral obesity or polycystic ovarian syndrome, they will also have higher levels of cortisol. And then just severe physiologic stress. So let's be realistic. Most PA students always probably have high levels of cortisol going through their body. Caution should be used, though, if you're trying to test for this condition because it's kind of taken with a grain of salt, and it's really confirmed in a non-acute setting because it's sort of an expected test. So there's really no reason for you to be doing a huge workup if you're expecting this to be a physiologic cause. Now, if you have a patient that's got high levels of cortisol, or you suspect that it's hypercortisolism that's probably pathologic, well, then you need to do the workup for it. The 2008 Endocrine Society Clinical Guidelines released sort of their recommendations on how to work this up. This is the most up-to-date. It has not been changed at this point since 2008, and you definitely need to know this. One important factor is that at least 2 first-line tests should be abnormal in order for you to make the diagnosis of Cushing syndrome. Why 2 tests? Well, because none of the tests that we have for this are really great, and so typically multiple confirmatory tests are required in order for us to make the diagnosis. Here are some lists of the first-line tests. There's something called a late-night salivary cortisol. There is also a late-night serum cortisol, which we'll talk about in a little bit. There's a urinary cortisol, and there's something called a low-dose dexamethasone suppression test. If you're going to get a urinary or a salivary test, it should be done at least twice. Why? Because the sensitivity and specificity are not that great, and they're not the greatest tests out there, so they want you to have multiple positive tests before you make the diagnosis. If you're getting a urinary cortisol level, they say that it has to be 3 times the upper limit of normal in order for you to include it in the diagnosis. Otherwise, it's inconclusive. And typically, this should also be paired with another first-line test in order for you to make the diagnosis. All right, since we were just talking about the urinary test, let's get into it. A 24-hour urine collection is typically the required test if you want to look at urinary cortisol. It's really the best way to look at it from a 24-hour period. Cortisol in your body is released in bursts, so therefore just doing a spot check lacks sensitivity and specificity, so it's not really good. So you're going to really need to get a 24-hour collection. There's some new data out right now that suggests that if you collect a specimen between 10 p.m. and 8 a.m., that's almost as good as a 24-hour collection, but it needs a lot more research and a lot more validation, and it is not recommended as a first-line test at this point by the Society for Endocrinology. The diagnosis of Cushing syndrome is made if the urinary cortisol excretion is greater than 3 times the upper limit of normal, and you have one other first-line test that is also abnormal. Here's why. Up to 40% of patients with severe depression or polycystic ovarian syndrome, they can have slightly elevated cortisol levels. People who drink large volumes of water tend to have higher levels of cortisol on a 24-hour urine. These are just 2 examples, but there are many more out there that can cause high levels of cortisol. This is why you need to make sure it's 3 times the upper limit of normal, and you need another test before you're going to make the diagnosis. Another first-line test is the late evening salivary cortisol. This has got to be done late at night, like typically around 11 p.m. Why? Because cortisol levels tend to rise at the initiation of sleep. So this is not going to be a good test to use in patients with abnormal sleep schedules or that are on a swing shift type work schedule. Morning cortisol levels have no diagnostic value unless they are extremely elevated. So therefore, it's not recommended as a testing option. So the way this works is that they're going to get 3 samples on 3 different nights. Okay, remember, around 11 p.m. Cortisol is really abundant in the saliva, and it remains stable at room temperature for several days, which makes this a great test for people to be able to do at home. So it's easily collected. They can do it very easily at home, and like I said, it's done late at night. For reasons that we don't quite understand yet, this test may be inaccurate in people over the age of 60. So take that into consideration when you're working this up. Similar to the salivary cortisol is the serum cortisol level, but it's also done in the late evening as well. This is based on the same practice that our cortisol levels tend to be higher at night. Now this is easily done in someone who's hospitalized, but it's a pain in the butt for people who are at home, because it has to be a blood draw. So some people suggest, if this is what you want, that you put a Hep block in them earlier in the day, and then you have them return to the hospital between 11 p.m. and 12 a.m. to get their samples. And they're recommending at least 2 nights of samples. So this is rather inconvenient for patients because they need to come in and have that Hep block inserted into their venous system, and then they have to come back to the hospital or the lab late at night. And frankly, I don't know of a lot of labs that are open at 11 o'clock at night for blood draws. So this is going to probably be ordered most often in your hospitalized patients as opposed to your outpatients. All right, dexamethasone suppression testing. Now there are 2 types of tests. There's the low dose and there's the high dose. These 2 tests are going to be used to differentiate the difference between Cushing syndrome and Cushing's disease. The low dose test is going to be done first, as this will help us establish the diagnosis of hypercortisolism from basically any other cause. The high-dose test is done specifically to differentiate between Cushing's disease and Cushing's syndrome. All right, so let's get into it. The low-dose test. If you have adequate levels of cortisol going through your body, that should suppress ACTH from being released from the pituitary gland. By providing dexamethasone and giving yourself basically synthetic cortisol from a medication, this should suppress ACTH from being excreted. So like I just said, if the HPA axis is normal, dexamethasone should suppress ACTH from the pituitary, and the overall cortisol level will decrease because we're not putting out ACTH. So once the drug wears off from the low-dose dexamethasone, cortisol levels will drop. Now, there's two ways to do this. There's an overnight test in which they get 1 milligram of dexamethasone between 11 p.m. and 12 a.m., and then we get a single blood sample at 8 a.m. A normal response to this should be a cortisol level less than 2. Or the other option is a standard 2-day test. This can be done as an initial testing or as testing following an overnight study. Dexamethasone at 0.5 milligrams is given orally every 6 hours, starting at 8 a.m. for a total of 8 doses. Blood then is then obtained 2 to 6 hours after the last dose to check for cortisol. Some also can check a serum ACTH with this as well. But a normal response to this should be a cortisol level less than 5 or an ACTH level less than 5 as well. The high-dose dexamethasone suppression test is not the first-line test for the diagnosis of Cushing's syndrome. Rather, this test is used to diagnose Cushing's disease. So this is based on the fact that ACTH secretion in Cushing's disease is only relatively resistant to glucocorticoid negative feedback inhibition, and so therefore will not suppress normally with low-dose testing. So in other words, if you do the low-dose dexamethasone suppression test and the cortisol levels and or the ACTH levels are still elevated, you have to do the high-dose test. By increasing the dexamethasone dose, ACTH suppression is achieved in patients with Cushing's disease. Now, you can have people who have a non-pituitary source that's putting an ACTH, an ectopic source, such as like a tumor from oat cell lung cancer. In this case, the ACTH production is not inhibited by glucocorticoids, regardless of the dose that you give. So if you have, once again, low-dose dexamethasone suppression test is given. If the cortisol levels are low, great. You've made your diagnosis of Cushing's syndrome. But if the cortisol levels are still high, then you should do a high-dose dexamethasone suppression test. If the cortisol level now is suppressed, awesome, you have Cushing's disease. If the cortisol levels are still not suppressed after a high-dose dexamethasone test, then you have to consider that there's another cause that's putting out high levels of ACTH, like a cancer. One other factor here to consider is that adrenal tumors that secrete cortisol, they don't depend on ACTH at all. They're just putting out cortisol. So dexamethasone suppression tests are really not indicated in the workup of an adrenal tumor. All you basically need is a cortisol level and a serum ACTH. The cortisol will be high, ACTH will be low. You made your diagnosis. In the other conditions, like the other cancers that we were just mentioning, the ACTH will be high and the cortisol will be high. In this case, if the ACTH is low, it's coming from an adrenal tumor. Now, the test is administered 2 different ways. You can do it overnight with 8 milligrams of dexamethasone given between 11 p.m. and 12 a.m., and then you get a cortisol level at 8 a.m. Or you can do the 2-day test, which is 2 milligrams of dexamethasone starting at 8 a.m., and you give it every 6 hours for a total of 8 doses, and then you draw a cortisol level. Now, you can measure an ACTH level, but it's not first line for the diagnosis of hypercortisolism. However, it can help us determine the etiology in Cushing's syndrome. All right? So, in other words, if we're not sure if this is an adrenal tumor versus an ectopic, source like an oat cell lung cancer, then maybe getting an ACTH level will be helpful in this situation here. So, if an ACTH level is drawn after a high-dose dexamethasone suppression test, the ACTH will be high normal to high in patients with an ectopic ACTH syndrome like an oat cell lung cancer. It'll be normal, within normal limits, if they have Cushing's disease, and it will be undetectable in those with an adrenal tumor. All right, so hopefully that helps clear it up for you. I know we talked a little bit on the previous slide, but hopefully this clears it up for you. All right? Well, folks, that'll do it for our presentation here on hormones and friends. As always, if you have any questions, feel free to stop by my office or send me an email. Otherwise, good luck with your quiz, and reach out to me if you need anything. Thanks.